Please call this meeting of the Opioid Abatement Funding Advisory Board to order. I ask that you please turn all your cell phones off or to vibrate. I don't see anyone in the audience in the public to speak, so I want to address that matter. If we would, we can stand up and do the Pledge of Allegiance, please. All right, looking at the agenda here, the first item on the agenda is the election of chairperson and co-chair for the interim, for the next year, fiscal year, ending next October. So, entertain motions.
Yes, I motion that the interim chair and vice chair that we elected at the last meeting be elected to the positions in which they're in at this time.
I second that.
Is that acceptable? Doing both of them at the same time?
Well, you can, if there's a discussion, anybody objects to that, but if no one's going to object to it, then you should be fine.
All right. Any objections, any discussion? All in favor, signify by saying aye. Next, you have in front of you, thank you very much, appreciate it.
So
I guess,
for the record, it's going to be John Mathis as the chairperson and then Catherine White as vice chair.
okay, thank you.
Thank you.
I say I appreciate it, I guess I do, we'll find out. Next, you have on the agenda is approval of the minutes of the last meeting. Has anybody had a chance to look that over? Any additions, deletions, or comments concerning the agenda? I mean, the minutes?
I make a motion that we approve.
Can I have a motion?
Second.
All in favor, aye? Aye.
Aye.
Passes. Yes, seeing no public comment, Christie, are you aware of anyone that's going to be here or coming, public-wise, I mean?
We just have the two speakers that are on the agenda.
Okay, thank you. Next on the agenda is the discussion and voting on the bylaws that were distributed to you via email. Hopefully everybody's had a time at least to look them over. Myself looking at it, I didn't really see anything I had any concern with. I like the removal of vacancy, and if you can't be here, unexcused absences and that sort of thing. But anybody have any comments about the bylaws? Additions, deletions? Seeing none, hearing none, this time we'll vote on the...
I have one. In the duties, it says the board must annually make recommendation on funding programs, things of that nature. How that reads, it says like, almost reads as if we're only going to do that one time. In the last meeting, we discussed that as funds come in, we would kind of discuss how that would be managed. So we may need some clarity on that part right there, because it's, the way that reads is kind of like we're doing it one time a year.
The way that came directly from the board's resolution, the Board of County Commissioners resolution on this.
Mm-hmm.
We were going to have a procurement speaker this time, but she's unavailable. So the plan is to have a procurement speaker, Lindsay Stevens and Wes Moreno, to speak with you next time to go over that and how that provision works, and to also make sure we follow the county procures. So what we're looking at is, you'll note we don't have any funds right now to do any budgeting with. So we kind of have some space on that if we wanted to come back and bring these bylaws back in front of the board once we have the procurement speaker to do clarification on that, because I want to have a clear understanding of how that's going to work, and have them define it for you since it's their department. So, but that's exactly, we took that exactly from the resolution that created this board, and so we have to at least include it. and we can further define it after we have a better understanding.
Thank you.
Along that line, I want to make the board aware that these notebooks we gave you, the bound ones, we're going to go back and put them in notebooks like these, so you can add things as it comes along. And we were just waiting until we finish the bylaws, so you'll be getting that with your full bylaws in it. So if you want to snap anything in and out, you can change the pages if you made notes on anything, but this will be an easier notebook for you to use.
Thank you, Christie. Tommy, you have any further questions or clarifications?
No, Chief, that's it. That's the only thing that kind of jumped out on me. Everything else is kind of like, regular procedures.
There is one matter that you'll need to address. Under Article 4, there's a required annual meeting under Section 3. So you'll need to set the date of that required annual meeting. That doesn't mean that you won't be meeting throughout the year, but you need to set that date.
So these meetings that we do on a monthly doesn't kind of like suffice for that annual meeting, one of those annual meetings?
This is another requirement of the BOCC resolution.
Okay.
So we've put it in there. If you want to, you don't have to vote on these bylaws yet. You're pretty much under these restrictions anyway, because most of this came directly from the BOCC resolution. So if you want to wait to vote on your bylaws until after we talk to the procurement, or if you want to set that date, that might be a good idea to have more information, and you can just agree to follow these as a draft until we get to that point.
Okay, any more discussion on that? Is everybody acceptable with that? All right, we'll just, at this time then, without vote, we will pass this on until after we hear from the procurement officer, and then we'll make determination on the specific date for the annual meeting. All right, Christie, did you have any more questions from the previous meeting that you want to discuss with the board?
There had been some questions. One had been whether or not CDAC, the task force, was subject to the public records as well as the Sunshine Law. And that, researching the dispositive question on that is going to be whether they're a decision-making authority or they're information gathering or fact-finding. And from what I can read among their responsibilities, it's going to be fact-finding. They're not going to come to you and tell you who you should select, but you're going to go to them with questions of things you need to know. So if you wanted to know, I think there was a question of how many providers are there available so you in this region. So that may be a question that you would put to them to say specifically how many Narcan drugs, who has this and how many people can we get it to? How can we get it more into the community? So that would be a question for them, for your CDAC task force to answer for you and come back to you with that information. So as long as their job is fact-finding and that they're not making a dispositive decision, I don't think that there's a problem there with Sunshine Law. So they can, otherwise, how would you ever get anything done on your task force? It's much like having they're your staff, except you don't pay them, okay? The other question that came up was procurement. We're going to deal with that next time with Wes Moreno and Lindsay Stevens. That also included the single budget question. And then finally, there was a question about contact with BOCC. You're not on the same board when it comes to contact with BOCC, so Sunshine Law may not apply. The main thing you want to make sure is it's going to come down to what's the content of the conversation. If you have someone from the board coming to you saying, we need more treatment facilities, or you get an order from the board, so they have a discussion after perhaps one of you has to do a presentation, Chairperson Mathis, you have to do a presentation, and they go to you and they say, we want you to come up with this. We want you to find more information about this and come back to us. So that type of thing, we're looking for more information on how we can provide these services. That's one thing. But for someone to come to you and tell you, go to this company, that's different. So just understand that it's going to be based on the content of the conversation. So just be careful that you understand that they're requesting information, and it makes sense that the BOCC would be asking you to get more information or this community really needs housing, or this community, and to give you some direction on where you need to go. So just keep that in mind as those conversations will come up, and they will come up. You'll see them. You'll see the board in other areas, and they, like I said, they may issue things when they're on the dais, and they may issue discussions that they want you to look into. And I think that covers most of the questions. Is there anything else that I needed to cover?
So the task force, which is CDAC, that's more of an advisory committee. You can
They,
go,
they are a fact-finding committee, so they're not voting to make decisions.
okay, so we can go to them when we want to find out certain stats, or we want to find out certain, basically the numbers on these, in this particular area and things of that nature.
Right, so one of the questions last time is how many providers are there in this area? And I believe we left it with them to look into that. And that would be, and if the board wants to come up with a question that needs to go to CDAC, you could also do that here. This would be a good place for, then you have that out in the public record. These are things that we want them to look at. That'd be another way to do that as well, is issue a directive from this board over to your investigative, really they're just investigative or fact-finding. They're not coming back to you with a decision. They're just telling you, this is what we found based on your question.
Okay,
Okay?
thank you.
Sure.
Any more questions of Christie from the board? Especially in reference to the CDAC piece of the puzzle here? Seeing no one else has any more comment, we would, like I said, we would defer the bylaws till later. Obviously, we've already done that, but I think we are, like I said last time, we are learning to walk or crawl before we learn to walk on this thing. And I was kind of under a different impression of CDAC. I thought they were going to be coming to us with recommendations for us to, yay or nay, we agree with that fund, recommend funding to that. And I thought they would be more the advisory, more the decision-making, that they would say yay or nay to our advice, or, our advice, I guess.
So the procurement that goes through the county has its own special committee that handles that type of thing. And so that's why we need to hear from procurement to make sure, because they run the ads, and they have a small committee that makes that decision as to what to get to you, what should get to you.
Okay.
But the advice that you can get from the CDAC is to understand where are our hot spots that we need to address things with this board. And that's really, because you're not supposed to do your own fact-finding, and you have someone at your fingertips that's available to do the fact-finding, that may be the best thing, is to go over the A's and B's, the attachments that we gave you, and that's something that you can do here in the public forum as well. And you can prioritize, you can do it on your own time, figure out what it is you think we ought to prioritize, and then get in touch with Tina Arroyo and let her know, for the next agenda, I want to have this on the agenda, a discussion of the priorities that we need to be looking at. And she'll put it on the agenda and send it out to you, and she sends those, she gets those agendas out to you blind copy, so you don't run into the risk of communicating with each other outside of sunshine law.
So, I'm sorry, Dave.
Go ahead.
So as I understand the process, the procurement department has their committee. They're going to put it out for advertisement for people, funding for this particular thing. An organization, an agency, a whatnot group will come in, let us know what they do, how they do it, things of that nature. They would come before us, kind of like present their, case for funding. And then we would recommend up to the Board of County Commissions of what we decide. Is that how that process kind of works?
That's why I think it'd be best if procurement explains it. I think that's the bare bones of it, but I think it's a lot more involved and detailed as to, because they have their own, if they're going to handle the procurement for these, if they're going to send out all the paperwork. And I know Tina Arroyo works in that department, but I think she's new in that department. So I can see that she's not wanting to answer that question either. So it's best to have somebody that's higher up in that world with a greater understanding than we have. But I think you've got the bare bones of it.
Okay.
If I could follow on with that. So is it not, what you were saying earlier, is it not this group's responsibility to at least kind of come up with the priorities of the areas to be funded? Am I understanding that correctly? And then basically procurement would follow on with putting out notices of availability based on those priorities? Or am I misunderstanding our role? Or the process, not just our role, but the process?
So the question that came up earlier about what date to have a meeting, the annual meeting, it's a review of the previous year's data, and the data should include evidence of the local status of the opioid epidemic and effect of abatement programming. So that's a primary focus of of the committee, of you as a committee, of you as a board. And then as far as the procurement process, what you'll meet on is decide, so when I talked about earlier, say, I think that this is a priority and we need to have a meeting on this, and you communicate that to Tina, and she puts it on the agenda. Then at the next meeting, and you'll all receive that agenda, then at the next meeting, you would come to that meeting prepared to discuss whether or not that is a priority of this board. And then we're way ahead of ourselves because we don't have any funds right now. And then procurement would become involved at that point, as far as you would need to establish what your parameters are, what's important within that particular topic. I think even Torcell knows more about this than I do. And so they would come up with that discussion. You would have that discussion, and then procurement would get involved. But I really think we need to get to them first before we can,
Okay.
and they can give you a clear understanding of what the process is after that. And once we understand the process, it should flow easier.
Thank you, Christie. Doctor, is that, okay. I think what Christie's trying to say here is we got a bunch of blocks we got to bring together and build this thing. And I think that till we get all the pieces, we're rightfully so, we're asking a lot of questions, but we really don't have the answers till we hear from all the parties concerned and get all the information in front of us. So with that being said, any other questions about that or comments? This time, Christie, I'll let you introduce our guest for our presentation. I think that's next on the agenda.
So Chief David Torcell is present from the Escambia County EMS. You had asked for some information. You wanted some more background, and I believe you have an EMS dashboard. Is that correct? So he's gonna walk you through the presentation. He's going to walk you through his presentation. He's very familiar with opioid abatement. We were fortunate to watch him answer several questions in front of the BOCC, and he comes to us with a lot of recommendation from CDAC. They just think the world of you.
Mr. Chair, board members, good morning. Thanks for having me here. This is a good opportunity for me. I've had the opportunity to speak at several places to get some information together, but as the weeks continue to go on, it's unfortunate because the information I'm going to give you today is just astounding. I just checked our dashboard this morning. As I reported about 3 weeks or so ago, we were encroaching on that 1,500 mark for overdoses for the year. We ran 1,095 last year. So from January 1 to December 31st calendar year for last year, we Escambia County EMS, responded to and handled 1,095 overdoses. And a few weeks ago, I was mentioning that we're very quickly approaching 1,500, so as you can see how the numbers are quickly almost doubling last year. However, I checked our dashboard this morning and validated that through some of our information systems. As of this morning, which is 10/17, we have run 1,677 overdoses. We're about to hit 1,700. 39 overdoses last week we ran, just in a 7-day period. So if we stay on that approximate 39 to somewhere low 40 mark, which seems to be about the norm, we will meet that number of doubling our overdoses since last year. When I first came here as the EMS chief, one of the things I was looking at, obviously, my first, get a snapshot of what are our big issues here. And this by far is the one that jumped off the page at me was I've just never seen what I've seen here when it comes to overdose and drug use and the addiction problem that we have in this community. With that, we were fortunate enough through EMS to be selected with other community partners. So our 3 local hospitals, which we're very fortunate, all 3 of them are participating. A lot of communities we've found in our meetings with the state, we do a weekly meeting with the state, and we do a weekly meeting the following Monday with our community partners throughout the state that are in EMS. And we're finding that a lot of communities are having difficulty just getting that one first hospital on board to do this program that I'm about to explain to you. We were fortunate enough where we have such a good relationship with our 3 local partners, all 3 of our community hospitals. So Baptist Sacred and HCA Florida West Hospital are participating, which for us is just a phenomenal opportunity. The program we've been selected for, it's called the CORE program. You may have seen, we did a press conference about 3 weeks ago with Dr. Shepke and Dr. Latipo, the State Surgeon General. They were here locally. We did a televised conference to kind of discuss this program and what it's going to affect in our community and how it's going to help. This whole thing, although it is obviously a team effort, really swings hard around EMS because we see a lot of the components. So for me, a normal, or for our service, a normal overdose response would be we respond to the field, we pick someone up, we transport them to the hospital depending on their state, whether they're unconscious, unresponsive, perhaps they're in respiratory or cardiac arrest, which would be the worst case scenario, or they're just not themselves because they're under the influence of opioids. We would take them to the hospital, they would get whatever treatment necessary, and then potentially they would either A, get a referral for addiction therapy from the hospitals, or they would be discharged without agreeing to receive those services, only to go back into the community, and I say this all the time, wash, rinse, repeat. We go pick them up again, we take them back to the hospital, same thing over and over and over. So at what point can we do something that's going to change that cycle? And this CORE program is Coordinated Opioid Recovery Effort. The E is supposed to be kind of silent, but I added the E for effort because I think that's what it is. This is a community effort amongst all of our partners. And what we're doing is we're changing the way that this is being looked at. We're changing the way we're providing service, and we're getting involved. More so involved than we are just for the 911 call to pick them up and take them to the hospital. We are actively engaging in, once a patient goes to the hospital, the physician staff who are going to be training all of their emergency department folks, which they're working on right now, all their physician staff, they're going to be doing a process called induction. That's where they offer these services for addiction therapy. It's medication-assisted therapy. So through medicine that gets them to that level, even keel, it's the easiest way to describe it without getting too far into the medicinal side of it, and allows them to have normal thought, allows them to have what is that normal basis to make good, sound decisions, to want a different life than what drugs have given them. With that, these people agreed to do this, and we're seeing it every day now. I've actually talked to one of our local physicians, Dr. Mark Stavros. He's the medical director in charge of the ER at HCA West Florida. And he's actually doing induction processes, even though our program is not physically up and running 100% right now. We're still in the processes of getting everything together. So that's encouraging, because not knowing those other legs of this process are together, he's already seeing where these people want help and they want to go through these processes, but they don't have those extended things. And the biggest thing that we've identified is, and the easiest way to say this is, if a person is addicted to drugs and they go to the hospital and they get the treatment and they're ready to be discharged, and you give them a piece of paper that's a referral that says, on this date, this time, go to this appointment and they're going to help you. Good luck to you. Where are you going to see him again? You're not going to see him again. I'm going to see him again. My crews are going to see him again. We're going to pick him up in the field. We're going to take him back because they're going to go back to those poor behaviors. They're going to go back to those environments that foster the decision to use drugs. So we figured, okay, how can we avert that, or how can we try to negate that? What better way than before they're discharged and they're going through this induction process than to have our EMS staff, our community paramedicine team, which is also part of this new program. We're going to have community paramedicine. It was typically called community paramedics, and you may even seen it as MIH, which is mobile integrated health. We're going to be meeting these patients before they ever leave the hospital. We're going to be able to sit down with them and say, hey, you're not in this alone. We're here with you. These are the faces you're going to see that are going to meet with you every day, every 24-hour period, whether you're couch surfing, whether you have a home, you live in an apartment, whether you're a homeless encampment. We're going to be the faces that are going to meet with you and give you this medication every day to keep you on this level, even keel, to make those good decisions. And the medication I'm referring to is Suboxone. If you've never heard of Suboxone, Subutex, it's a medication that Again, the easiest way to describe it is it gives you clarity of thought. You're not up here with the high, you're not down here at the low, you're here somewhere in the middle. And it's a transitional period. It gives these patients the opportunity to start thinking clear, know what they want to do, know their direction, and have someone that's going through that journey with them. You're 10 times more likely, if I tell you, I'm going to meet you every day at your house, and I'm going to check on you, and I'm going to do vital signs and do an assessment, and I'm going to find out what other needs you have. Do you have a phone? If you don't have a phone, well, I need to get you a phone so you can contact me when you go through crisis. What's your food situation? What's your utility situation? Do you have other co-medical problems going on where maybe you have hypertension or diabetes or a cardiovascular disease and you're having trouble getting those medicines? We're going to help you get that too. We may not be the resource to get it for you. We will get you in touch with the people that will get you those needs. And it's all inclusive. You're 10 times more likely, if I offer that type of service, to go, I'm in, than if I just say, make sure you show up at that appointment 2 weeks from now, because it's not going to happen. I mean, let's be realistic. We know it's not going to happen. So with that, what we're going to do is our community paramedicine program is going to be meeting these people every day up until the first day of their appointment with addiction therapy. Now, Community Health Northwest Florida is our community partner. They're our FQHC. They're going to be the ones, they brought on additional staff, and actually, Chandra Smiley, their CEO, we're in communications almost every day. She's already hired some of her staff through this funding that's coming from the core program from the state. So she's bringing on additional mental health professionals, additional case managers, social workers. Through this, I'm able to get 4 staff from my community paramedicine program, which we're hiring registered nursing staff. I do have some that have interest in working for us that are also nurses, and they have their paramedic license. So that's full circle. That's fantastic. And I've also been able to get 2 drivers out of this. And the reason I have 2 drivers is because they're EMT drivers. I was surprised when I found out one of the biggest problems for these people getting to long-term addiction therapy appointments is transportation. No one's going to ride their bike in the rain or walk in the rain to an addiction therapy appointment that's 6 miles across town or 10 miles across town. I also believe that you should have access to the same service at 3 in the morning from my service that you do at 3 in the afternoon. So our community paramedicine program is going to be 24 hours. So whether you need help at 3 in the afternoon or 3 in the morning, we have the staff available to come to you. If you're having a crisis, if something's going on, we're going to come out and say, okay, what's going on? Maybe it's a craving, maybe it's an issue, maybe you've been put around a circumstance that's making you think the old way you used to think when you were, hot and heavy into drugs. Let's get you the help that you need right now so that tomorrow when the when the FQHC is back up and running, because they have specific hours, they're not 24 for some of these services, or do we need to take you to a hospital tonight because there's something a little more involved? But we're going to get you where you need to go so that you don't just decide, you know what, easiest way for me is use drugs and go right back to where you were. This program was actually started in 2018 in Palm Beach County. Palm Beach County Fire Rescue was the first in the state to do this. They have had phenomenal results with this program. Now, one of the things they are fortunate to have that we don't have is they have, it's a centralized receiving facility, but this centralized receiving facility that they have is an actual all-inclusive addiction therapy, mental health, and emergency department. It's all in one. So, that's huge. It's called the Kennedy Center. For you to be able to have somebody where you have ER staff, just like you do in an ER, plus mental health professionals, plus addiction, that says a lot. But, I think we all know Palm Beach County in the name, they're very well funded. So what we said is, well, what can we do with the resources we have? What can we do to get us through now until we can get to the latter phases, maybe down the road, to have services like that? Well, one of the things is when we take these patients to their addiction therapy appointments, and by the way, we're going to be transporting them to and from through EMS. I've acquired some vehicles that we're going to be utilizing from ECATs, from their surplus. And our staff is going to be picking them up wherever they're staying, taking them to their appointments, and picking them up from their appointments and taking them back. Because we want to make sure not only are you making it to and from these appointments for what you need, but if you start to have familiar faces that pick you up and take you to and from every day, you start to get dialogue. You start to get familiarity. You start to get comfortable. You start to open up. We can have someone who just says, hey, how's things? Maybe I find out you're a Boston Red Sox fan. Hey, did you watch the Red Sox the other day? You start to get that dialogue, and now I have a vested interest in who you are as a person, not just, I'm giving you a ride. Not just, go to your appointment, good luck to you. It's personability. It's, hey, I care. That's why I'm here. What else can I do to help you? What other needs do you have? It's my personal belief, and we'll see when the results come out as we go through this process, but I can tell you that they're in the 80 percentile with Palm Beach County, with those that they've actually done through their induction process and retained, because some people need long-term addiction and mental health therapy. It's not just a quick 90-day fix and you're better. Sometimes it's what they call lifelong therapy. With that, I had a discussion with Dr. Shepke at our press conference, and he told me the second patient that they ever brought into their program in Palm Beach County, he was their medical director at the time, called him just a few weeks prior to the day I was speaking to him, and was calling him from Belize. And he said, "What are you doing in Belize?" He said, "I'm getting married. I've got a life. I've got a wife. We have kids. I have a job. I have a house. All because of what you have done with your program. I just wanted you to know where I'm at." I thought, what an amazing thing for someone to go from, for them, the lowest of low, to call the person that was kind of overseeing this project and go, "Hey, I just want to let you know, I'm a completely different person and I have a completely better life. Thanks so much." So this program, we believe, will make a tremendous difference. Now, a lot of people, ever since this has been out in the news, there's been questions about, numbers and data and what have you. I'm collecting numbers and data like you wouldn't believe right now. One of the things I looked at was out of these, and this is a newer number, the 1677, go back about 3 or 4 weeks ago when the number was a little bit lower. I looked up, we actually pulled numbers on how many of the approximate 1,500 at that time were specific to opioid. Because if you hadn't seen one of my previous discussions, Escambia County in 2019 and 2020 led the state in morphine overdose, heroin overdose, fentanyl overdose, and cocaine overdose. Those 4, all in this county. So with that, we have to be able to separate. Some of those overdoses are someone took too much of their prescribed medication. That is an overdose. But I firmly believe that there's a lot more of this with the illegal drug use. So of the numbers we ran, 937, going back 3 weeks ago now, were all related to opioid. Then I said, let's dig further. How many of those are repeat patients where we've taken them to the hospital, gone back and picked them up? About 16 of those 937 are just continual. We pick them up, take them to the hospital, they get discharged, same thing over and over again. One of those individuals, calendar year now, January 1 to whatever 3 weeks ago's date was, sometime in September, we had seen that person 8 times since January 1. So we're almost averaging once a month we see that patient. However, when I looked at their encounters, because I can go through and look at the dates of service, there was a period during the spring where we didn't see him at all, and had I looked at the data at that time, we probably would have thought that person was deceased because we weren't seeing them anymore. Some of the times they go to the hospital, we don't know what their outcome is. Unless my crew is there long-term or we're able to follow up, we don't know that they were discharged, or we don't know that, unfortunately, several days later in the ICU they died. So that's data we don't know until it goes to the state, is reported through the state medical director, and then we see it from the fusion center later down the road. But I'm tracking all of that data as well. Because if 937 out of approximate 1,500 at that time are opioid related, and we can affect even a small percent of that, think of the tremendous number of reduction we're going to see. And just as I told the commissioners in my presentation, they asked if we were working with law enforcement. Well, yes, we talk to law enforcement. We try to give them any information we have. But at the end of the day, we're not law enforcement. That, the 2 separate components trying to work together using different avenues. So I figured if I can't stop the supply, what I can do is stop the demand. And we're going to do that through therapy, medication-assisted therapy with these folks, where they can get a normal life back, as normal as what anyone would consider possible. I don't think any of us have what's a normal life, but something where they have a job, they have resources, they have food, medications they need, they have family, they have friends. And we're going to expand that into some other things. I've been working recently with Elizabeth Kissel, program coordinator for grants with the county. There's a grant available that's in the process of being submitted right now for us. It is a transitional housing unit grant and it is specific for homeless individuals with addiction. I mean, I couldn't have put my finger on the button any closer to say it's exactly what we need. And what our goal is we've already looked at some properties here in the county, including some that the county already owns. We want to find a place for these homeless folks to not only have a place to stay, but a place that provides them accountability and structure and rules, and a place for us to know where they are so we can follow them through this journey as they're going through medication-assisted therapy, mental health professional treatment, etc., to get them back onto their feet to where when they finally have the ability to get a job, to get the services they need, then they can transition from there to their permanent place of residence. So there's a lot of things going on with this. We're in the final phases. The scope of work for EMS has already been done. Our community partners is done. The hospitals basically are, they're going to be providing that front-end portion where they do induction therapy. Some of the funding from the core program, we've set it up with our budget and our group to where each hospital is setting up a room in their emergency departments or somewhere they're close to it. We felt as a group, if someone comes in with an addiction problem, to be in the middle of that hustle and bustle of the ER with all these people coming at you, that's the last thing you want. How about a place that's a little more private, a little lower lighting, a little more quiet, a little more one-on-one or two-on-one where we can say, okay, here's our program. Here's what we're talking about doing. We're going to follow you through this journey. It's just those little things. Sometimes it's the smaller things that make the bigger difference than it is, these grandiose. Listen, I'd love to have a Kennedy Center like Palm Beach County. If you can find a way to do it, please let me know. But in the meantime, these are the things that we're going to do that we feel very strongly will be successful. The transportation to and from the appointments, that's a game changer. A transitional housing unit for the homeless, that kind of fixes more than one problem, right? That's a homeless issue, but it's also an addiction problem. And at the end of the day, it's our hope that we're just making people's lives better with as much as we can. And it's my belief if I save one life, then I've saved the world, right? That's true. It's very true. Any life we save, you've managed to save the world. But the numbers that we're seeing out of these other programs, I have to give credit to Clay County as well. Clay County does a medication-assisted therapy program, not as robust as what Palm Beach County is doing, but it's been very, very successful with keeping people off of drugs. I've met with some of our law enforcement partners. One of the things we see that I think is very important is we can look during any given time period during the day in EMS and say, and this goes back 4 or 5 months ago maybe, we had 19 overdoses in a 24-hour period. Well, we can bring up on a map, where did all those overdoses occur? And you start to look, it's a concentrated area. Well, what we're finding out, and again, we depend on our law enforcement officers for the information, is, I had to learn this, drug dealers will make a new batch of drugs and give free samples out to the street because those are test samples. Let's see how they work. Let's see if people want them, or does it kill people? Then we got to go back and make a new batch. It's just as simple as that, just like any product you were to make to sell in the store. Does it work? Is it effective? Well, if we can see this area on a map that looks like a 6 or 8 square block area and go, wow, that was all in that same area, we know where the drug dealers just dropped off their drugs. As we start to see those progress almost live, if you will, we can contact our law enforcement partners and say, hey, we've already run 5 overdoses, between these 2 streets and these 2 streets, north, south, east to west. And they said they will send resources over there to start looking, start figuring out what's going on before it gets to the point of 19. Because sometimes you don't realize you're just in the hustle and bustle of running calls and getting people to the hospital, that it takes someone like myself or some of my supervisors to step back and go, wait a minute, where did all these overdoses happen? This isn't just countywide. This is a heavily concentrated area. And then it gives our law enforcement officers the ability to do some other things that perhaps they didn't have information on, and it gives us the ability to make contact with more of these people. Hey, we have a program, here's what we're doing. So I think in the end, for us, the core program is going to be just a significant opportunity. We certainly expect that we will see little hiccups along the way where we have to revise things because maybe it works better than what we thought, so we need more resources, or we have to change a process or a platform. But I will tell you, there's 9 counties in the state that were selected for this, with 3 kind of, I'll say, in reserve. Their leadership hasn't given them the full blessing to take the funding and go with it, but they're attending the meetings so that when it is time for them, they're not left completely behind to go, okay, catch us up on a year's worth of work. But I will tell you that of the 9 counties, we are eons ahead of everybody else with our platform. I mean, we've already got Dr. Stavros, setting up a training platform for the physician staff with the ERs. My scope of work and everything is going to be on the next board agenda for the 20th for us to hire our nursing staff and our EMTs. We meet regularly. We've had shadow days where the FQHC staff went over to the ER and shadowed the doctors. I've gone over with my staff to the FQHC to watch their processes, to learn what they do and how everything works. So we all, even though we may not be doing the same job tasks, we all understand how each organization works and how important it is for us to have, that sinuosity together, just that seamless transition. And what it is in the end is it's case management. We're not going to let you flounder out there and wonder what's going to happen next, we're going to follow through this program with you. And I think that's the biggest thing that's been missing in a lot of communities, not just ours. Someone needs to be there to go, I got you, and I'm going to be here with you, and I'm going to make sure you get to that appointment, not just hope that you get there, and maybe I'll see you again, maybe I don't, because that's just not good enough. It's not good enough. It hasn't been good enough. If it was, I wouldn't be having little sticky notes here with 1,677 written on it because I had to write all this information down this morning. And I do believe there's a direct correlation. Last week, we ran 48 respiratory/cardiac arrests as well. There's absolutely a direct correlation. Obviously, there's some that have medical conditions and cardiac problems, et cetera. But a specific number of those are going to fall into that 39 overdoses for last week as well. So we could see a significant declination in a lot of things with the services we provide. We want to continue to move forward with ideas, thoughts, processes, any help we can get for this program. Currently, our funding from the state, it's currently coming from the Department of Health. That is set to expire at the end of July next year. The discussion is it will be moved over to DCF through the managing entity, Northwest Florida, starting possibly August 31st, but those details, right now they're distant to us. We have to focus on the here and now, which is the next 1 year that we know we have this and make a go of it. I've done everything I can with my budget as well to make sure that these positions should, worst case scenario, if something happened and funding's not available from those entities, we will do what we can to make sure we keep this moving forward because it's too important to let it go. That's kind of it in a nutshell. I know I just said a whole lot. But there's a whole lot going on, which I guess is a good thing for our county and a good thing for our citizens. So certainly any questions you have, if I'm able to answer for you, I'd love to do so.
Yeah, thank you, Chief, for that presentation. That's pretty informative what you put together. A couple of questions, and you may have looked at this when you were doing your study. Is there a large problem with the homeless population that we have in the county? Are you seeing a lot of that? And also, what areas in the county are you seeing this the most? And I think those are my only two questions.
Very good questions. Yes, sir, we do. There is a direct correlation, as you know, to the homeless population with both, and Dr. Williams can speak to this, ad nauseum with everything he's seen and a lot what he knows about this in both the addiction and mental health capacities with those. I think some of the numbers can be skewed sometimes and hard to maintain because, homeless communities move, patient encounters change, so keeping track of folks that don't have a regular place to be able to follow them, as I mentioned, the transitional housing unit, sometimes makes it difficult. So when we try to say we're doing the best we can with what we're following and what we're able to track, that's the truth. Sometimes you just can't get the numbers you want, but we know there's an absolute direct correlation to the homeless community as well as, addiction, drug use, and the mental health component. Without a doubt. And numbers you're going to see various numbers given by different organizations, but they're high. They're very high. A lot of people, there are those people that choose to be in the situation they're in and they don't want help, but there's others that are there just because they've fallen hard times, and then they fell on harder times, and then they turned to drugs, and then they fell on even harder times. And now they actually have, and Dr. Williams will attest to this, they have a disease. A disease is mental health. A disease is addiction. When I had my discussion with Dr. Shepke a couple of weeks ago, you can actually see on a CAT scan the neurological areas that are affected by someone with addiction. If you can see that, just as you could a stroke or traumatic brain injury, then that means there's a source, and it is an actual thing, not just something that's made up. So, and forgive me, what was your other question, sir? The one about, please, go ahead.
What areas of the county? And also, I don't know if you have this, are most of these people unemployed or some of them employed, have jobs, and they're just suffering from addiction? Any information on that?
So let me answer your first question first. So we have, hot spots that we're able to track very easily for us with the report writing software we utilize, which we got new last year. It's fantastic. I can run a lot of reports if you just know how to put the information in. 32505. I'll tell you right now, zip code 32505 is the hottest spot we have in this county. Then, of course, it's separated out into various other areas, and I have a map I could show you on that. But 32505 is the one. With that, I want to make it clear, too. I had some people that, when they first heard about the CORE program, called and said, hey, I've got a loved one who suffers from addiction, but we live in the north end of the county, 30, 40 miles up to the north end of the county. That's okay. I made plans for that. We're going to come pick you up. We're going to take you to your appointment. We're going to take you back. Nobody, just because of geographical area or because of funding or because of a job or lack of a job or where they live, should have to choose between, do I get the help or don't I get the help? Everybody should be able to qualify for that. I just kind of wanted to throw that in there. So yeah, 32505 is probably the biggest we see. It's kind of spread out. I think the bigger thing for us is to identify our patients by encounter, because if you just get caught in the hustle and bustle every day of, well, we just took another overdose, till you start realizing, and I think I've said this before, my staff actually run on the same people so many times that, you know, when you get them in the ambulance, if they're able to talk, you can almost start typing their history in before they tell you, because you've seen them so many times. That's a problem. You know, I don't want to know you so much that you overdose so many times that I can recite your allergies, your other medical problems, you know, what medicines you take if you have access to, et cetera. That's a huge problem. So we're really focusing on that so we can find those patients by name, because we want to be able to reach out to them and start them into our program and get them help. And then you had one more question you added there at the end, sir.
Just unemployment, if they were employed or unemployed with the addiction problems.
So we do not have a way for us to track that from the EMS side in the field. That's not really one of the questions we ask that goes through our history. But I can tell you we do track by age and by demographic. For us, opioid overdose, number 1 category, white males. Number 2 category, white females. Ages 34 to 39 in both. Those are number 1, and we're talking about opioids, mind you. We are specifically talking about opioids here. And then 34 to 39. Yeah, the employment thing, I would have to look to see. I would venture to say, because they ask a different set of questions sometimes at the hospitals. Hospitals might have that data. We look more towards, you know, age, the medical history side of it. And keep in mind, too, one of the things we're learning is there are folks that perhaps they're homeless, but our staff may not realize they'll give you an address that's either a bogus address or perhaps of one of the homeless centers or something like the Alfred Washburn Center. If they're not familiar with that address, my staff will just type, oh, okay, gotcha. And then you go back and look and go, that's not a house. Somebody doesn't live there. That person's probably homeless. So it can be very difficult to track unless you can have those one-on-one encounters with those folks. Yes, sir.
I have a question. You mentioned being able to go to the north end of the county to pick up people or to enter them into your program. So what does the, I guess, criteria look like for getting someone into your program?
That's a great question. So what we did was we followed Palm Beach County's original, their original plan, right? There's got to be some exclusionary criteria, like things like high-risk folks. So pregnancy, number 1, that's going to be a separate high-risk group that's going to be referred to specialists, and our folks at Sacred Heart are going to be focusing in on that specific for the women and children part of it. Because there are, the pregnant females that could have an addiction issue, but that's such a high-risk group that requires specialty care that we don't want to just say, oh, yeah, we can take it. We want to make sure you get to the specialty care. So things like that, they have on an exclusionary list. Certain things, just in general, we look at their background history. We look at things like, have they had addiction services before, medication-assisted therapy. There's also those out there that might be getting the, Dr. Williams, help me, is Vivitrol? The Vivitrol injections, which is more for, like a once-a-month thing that they give. And we have to look at those histories as well, because there's certain parameters that may keep them from being able to qualify for the MAT that we're providing in the tablets with the medication versus if they've already had certain other things. So, but there is an exclusion and inclusion criteria. What our expectation is in discussion with Palm Beach County and Clay County, we certainly don't think, if you take away the repeat patients, we don't think all of a sudden 900 people are going to just come out and go, okay, I want help. But what we do think is if we start with a group of 25 to 50 core members that we can get into this program, which is, believe it or not, a very good and reasonable number. Once those people start to have a positive effect on their life, according to everything we've seen from these other services, next thing you know, the people they knew in their previous life were like, dude, what happened to you? What's going on? In its simplest of terms, you look great. You're not on drugs anymore? You have a job? How did you do this? They now refer them to, to the program, and that's where those successive people keep coming in and coming in and coming in and being part of that program, whether they come in, they get their whole life turned around and they're discharged out of the program, or they need to maintain staying in the program for that, what they call, lifetime therapy that's necessary, because it is. There are those that need that, whether it's the mental health or addiction component, they need that. But word of mouth seems to be just as important through those patients to patients as it is us being there along with them in that journey to keep them in the program.
Doctor?
Good morning. I don't have any real questions. Well, I actually had a couple of questions, which you did address. One, in terms of the numbers of people you're kind of expecting to impact, and you just addressed that, and also kind of long-term funding picture, because as we know, that's going to be important in terms of sustaining the wonderful things that you're doing. But also just want to applaud the comprehensiveness of this program. As you mentioned before, we have different pockets and different pieces, but being able to provide that continuum with individuals, I think is just wonderful. So applaud what you're doing.
Thank you, sir. Thank you.
Tommy, you have a question?
Sorry, I'm kind of long-winded. I have a few. So understanding under this core program, so the core program was rolled out by
Florida Department of Health.
Florida Department of Health.
Yes, sir.
And you all have been tasked to basically, you're the ones that's going to be rolling this thing out, implementing it, and making sure it goes, correct? And structure. And so you have a number of, this is not all EMF staff. You guys have partnered with different people to make this structure move forward. In that process, now you're from encounter to therapy, right? The outreach piece on this, is there an outreach piece? What I mean by that is that an awareness piece, boots on the ground in the community to facilitate information, kind of like almost like a hands-on. And I know your staff, how many people you have on staff?
So total in EMS, we have 206.
206.
That's everybody inclusive. Operations, between my full-time and reserve staff, I'm at about 164, 174.
Okay, that's the county EMS. That's not the contracted ambulance services and things of that nature.
That's just Escambia County EMS for our county. That's correct.
Okay. Because what you just described is in totality of the program, what the services in which, that is monumentous. It is absolutely amazing for, and I think, an agency to be hands-on like that and to go through, because you don't, you think of EMS, you would not think of EMS as someone that's going to come see you every day. That is like, now you becoming a therapy organization, or almost like a rehabilitation type situation, which is amazing. And I applaud you all for that. Your target right now is, because you haven't actually officially launched, you were saying that somebody has kind of like started like a indirect intake and kind of like starting to do some things. So in that first year, say like this would you constitute this the first year yet, or kind of not really, or?
So the unfortunate thing I say unfortunate, the ball got rolling a little faster than I think the state knew to keep up with. So this original announcement was made August 4th by Governor DeSantis.
Okay.
Our program was supposed to start in July. We still, actually, October 20th board meeting, my funding request for these positions and to accept the funds coming from the state for EMS will be on the board agenda. But it's taken us that long to work on the scope of work, the parameters, the PO with the state. There's all these things we have to do because of the group, of the 5 entities, we are the only county entity. We have to follow,
Correct.
procurement and everything has to go through the board, versus the hospitals. They can just go, yep, we agree, our attorneys are good with the paperwork, and this is great, and yep, and go ahead, and they're ready to rock and roll. So ours is a little bit slower. But with that, for us as a team, it's worked actually very fast. And the good part about this is, on the front end, The hospitals have always been able to do induction therapy. It's a matter of physician knowledge, wanting and understanding and knowing to do it, where they can offer them this service to give them the first dose of this medicine in the ER and then refer them to addiction therapy. The question is would the patient end up in the addiction therapy program or back on the streets? And that's where the EMS component comes in. We're going to meet them to keep them from going back to that, all while they're waiting to go to their appointments. And the other thing I forgot to add is, even once they reach their first appointment and their successive appointments, and those mental health and addiction professionals decide, this patient's ready for less frequency on their appointments, they're ready for a monthly prescription of this medication rather than we give it to them one by one to see how they do, we are still, through our community paramedicine program, going to be scheduling appointments with them to just say, how's things?
Right.
How's your life? What do you need? What can we do for you?
And that's your staff doing that?
That's our staff through our community paramedicine program. That is holistically what community paramedicine is about. It's about going out to the folks, and a lot of people think community paramedicine is just for reduction in 911 calls. It's not, but it's a very huge component of it, because there's a lot of people, as we all know, that utilize the 911 services for services that are perhaps less than 911 worthy. But has anyone ever explained that to them, or do they understand that? There's those that, yeah, they do understand and they want to try to utilize the system, but there's others that don't. But there's also others that feel like they have no choice. For example, I'll give you an example. We will get called to a resident's house for someone that ran out of their hypertension, high blood pressure medication prescription, and they know they can't go without it for the weekend, but didn't get a chance to get it filled. So they figure if we take them to the ER, doctor will give them a couple days script for it to get them by until Monday till they can get back out and get it refilled. Well, guess what? How about through community paramedicine, we use another part of what we're instituting now. It's called Tele 911. I can bring a doctor to you on an iPad and say, here's Dr. Torcell. Have a discussion with him. What's going on, Mr. or Mrs. Smith? Oh, okay, and you ran out of that? Where do you get your prescriptions filled? Oh, it's CVS? Let me take care of that for you. Right there, they never have to leave their house. They never have to take an ambulance ride and utilize those services. They can have the prescription called in and get everything set, and they never had to go to the hospital through an ambulance and utilize all these other services that are more important for, heart attack, stroke, car accidents, et cetera. That's the premise of what, community paramedicine everybody thought was based on, was to reduce the need for calling for non-high acuity calls. But there's so many other things you can do. You can get people in touch with services that they've needed all along but didn't know how to get, or medication that they didn't know how to get or didn't know there was another program to help them afford something that's very expensive, because as we all know, medication is extremely expensive. So it's a full wraparound service to say, we want to get you everything you need, all without having to be transported to the hospital. And for those in the addiction, we want to continue to follow you through the program to make sure you're successful.
And last question. Once you say you get your funding and everything is in place, what is the number that you will be able to handle upon launch? Because I can see the floodgates kind of like opening and people. So now what is that capacity? Like, what are you build out capacity for to be able to handle in that situation? Because I'm sure you already have a crazy database of individuals that you're going to kind of like, are you going to initiate contact like, hey, look, we have this, would you like to come through and be a part? I know you say like 25, 30, but is that like the max number you would be able to facilitate in this program?
So part of this with the expectation, and it's going to be kind of an ebb and flow. So part of this is the FQHC, through certain processes, can only be allowed to handle so many at a time. And I want to say it's up to 50 in a specific program. But the expectation is, if we tomorrow were to have 50 people sign up right out of the blue, all 50 of those people aren't going to need long-term, addiction therapy, mental health. They are going to need a term. But we don't expect the same thing that, like Palm Beach County has. Some of them got in and got out, changed their life. They never needed services again. Others are still in it because they need that to keep them on the right path versus the path they came from. My hope is, as you suggested, and I have planned for it, I wish the floodgates would open, because that means that people are recognizing our service. They know we're there to help them, and they want the help. Statistically wise, about, that's why I gave that number 25 to 50. That's about what Palm Beach County saw in their initial inception as well, going back to 2018.
And that's on an annualized basis?
That's pretty much on the upfront and an annualized basis, knowing that as you have a few that over that period of a year step out of the program because they're good, or some may go back to their old ways, others will come in. So it's not the same 50 faces.
Right. And so the cost per person a year annualized, that I'm sure they probably got as is, that it would cost in order for a person to provide this service and care for them. Do you all have kind of like an idea what it would cost annually per person?
I do. So the funding that I put in for my budget was very simple and very basic. The first part is for the staffing. Obviously, as we all know, personnel costs are number one.
Right.
So for the 4 nursing staff and the 2 EMTs that are going to be doing transports, because addiction therapy is not going to be done at 2 in the morning to take them to transport, so it'd be a Monday through Friday type thing. Those, along with my fuel costs and the purchase of a vehicle for the community paramedicine team, was a little over $683,000. Now, keep in mind, that $683,000 on the front, now I've got the vehicle, so I don't need it anymore. You can take the vehicle off of there.
Right.
Fuel costs, they're going to fluctuate, which is why my regular fuel budget, just as any other service in this county, has had to go, looking forward, it's no longer approximately $3 to $4 a gallon. You have to budget high because we expect diesel fuel to go up again at any point. So some of those costs we've been able to kind of plan for in our budget. The annual reoccurring cost is simply going to be personnel and staff. If you figure with what we pay for state retirement, benefits, employment, salary, and to bring them on, it's approximately $112,000 a year for each nurse, and it's about $70,000+ a year for each EMT. That's all inclusive everything. A lot of people, I actually had someone say, wow, that seems like a lot of money to pay a nurse, and I said, you're missing the point.
Right.
That's not that nurse's salary. That's retirement. We pay county benefits for them. I mean, there's everything. We have to buy uniforms. That's everything inclusive. That starts to dwindle down to what the actual salary is at the end of the day.
But in this cost, that's actually providing all the service and everything for the people
Correct.
to come through. Okay.
There's no charge to the patient, so they're not being charged per trip. They're not being charged to pick them up and take them to these appointments. They're not being charged for the medication, because we've already worked with the managing entity, Northwest Florida, to purchase the therapeutics, and they've agreed to supply it for us. So all of that would be free to these
So that's like them going into a
patients.
facility, like a treatment facility, but it's like all, you like a treatment resort.
Yeah, and
All-inclusive.
and in the field, right?
Okay,
I mean,
yeah.
you don't have to come to a brick and mortar. We can come to you in the field, and it's all part of it, which we felt that was the biggest missing piece.
I think that's amazingly low,
What is? I'm sorry?
that budget for that. I mean, for that much hands-on and out in the field work and that, I think that's,
Yeah.
for you to do that in that,
So keep in mind too, the total budget that we gave to the state also included the money for the positions at the FQHC. That's just the money for EMS.
Right.
We asked for $50,000 each, well, actually $100,000 each for each hospital, because each hospital needed funding to train all of their staff, as well as $50,000, which probably they won't spend that much each, to build these rooms in their, in their hospital that we discussed. So $100,000 for each. And the state initially told us, we want you to stay around the $1 million mark when you make your submission. My initial submission was about 1.4 and change. And we said, how much is too much? But as Commissioner Bergosh mentioned, you always ask for the sky. Of course, but we didn't want to be ridiculous. So 1.4 was reasonable compared to the $1 million. And in the end, after they reviewed our budget, the only thing they took out, and it was because of what it was, not that we were asking for it, was the therapeutics. They said, we can't pay for that. Therapeutics have to come from someone else. That's the cost of medication. Northwest Florida, the managing entity, picked that up right where the state said, we can't cover that one, but we can cover everything else. And those are reasonable costs for the personnel, for vehicles, et cetera, for fuel, et cetera.
Chief, I don't know if you were one that actually orchestrated all this and got all this together, but if you did and your staff, man, you guys did it. I don't know if I can say this on record, you guys done a hell of a job. That's really, really good to orchestrate all that from a August 4th press conference until now, to get all of these entities together in a row to actually say yes and get all this on board and to roll this out. that is amazing. I've never seen the government work that fast like that, dude. That is absolutely amazing.
It's a testament to our team. I've said this in several of our discussions. Those five, the 3 hospitals, the FQHC, Community Health Northwest Florida, and EMS. I've been in public safety 26 years come this Halloween. It'll be my 26th year anniversary. And I've never, ever had a collaboration work as well as I have with this group of 5. I mean, just agreeable, deadlines we've met, schedules that sometimes were very difficult to get us all together, but we did. Teams meetings if necessary, while we're on our way from one meeting to another to make sure every I was dotted and every T was crossed. It's just a testament to these people and who they are. It really is.
Chief, I'd like to thank you for the presentation. Also, I would like to kind of fall in line with some other comments here. It's amazing what you and your team has done, and this starts at the top and goes down. And I realize, having been in law enforcement my entire career, and much like brotherhood with the EMTs and nurses and ERs, it's changing an attitude, a core belief in what your job is. From when you came on 26 years ago, you were just picking them up and going and depositing them at the ER and go get the next one, So just to get your staff to buy into that and become partners with you and with everybody else in this, I think is remarkable. And like I said, just a change in general work ethic and attitude and, holistic approach. But I appreciate all your effort in this. So thank you for your information.
Thank you, sir.
Anybody else have any questions of Chief? With none, Chief, like I said, again, thank you very much for the information. And Christy, did you have something?
I did have a quick question regarding that. Are you familiar with the core strategies that are in the county? As I listened to you speak, it was as if you were going through the core strategies that was within the interlocal agreement and our MOU with the state. Is that where this came? Is that where this program or these strategies came from? Was that original program?
A lot of those strategies are based on the same stuff. Obviously, that relationship and that those core strategies between us and the state. And the biggest thing was the identifying. You can't do the same thing over and over again, even if you have everything well defined and listed out. Here's what we're going to do. Here's how we're going to do it. But it's not working. So what can we do different? And what Mr. Chair just said. It almost echoes, and I'm actually paraphrasing what Dr. Williams said at one of our community presentations at the Brownsville Community Center. Why is it we can talk about cancer? Why is it we can talk about heart disease and diabetes and high blood pressure, but when you mention drugs, everybody goes, no. Why? It's an addiction. It's a disease. It's the same thing. Should it get any less treatment or any less care than any of those other previous diseases I mentioned? Absolutely not. It just needs to be treated in a different way. And we've utilized those strategies to make sure, obviously, we stay in line. And the state, of course, has given us some parameters with data and metrics that we're going to need to meet. Each community, kind of based on its size and demographic, et cetera, will be giving its own little version of it. But at the end of the day, it'll be inclusive of all the same information they're looking to see how successful this is.
One more question. Could you give them directions to your dashboard?
Oh, yes. The easiest way is if you just get on your search and type in Escambia County EMS dashboard, it will literally take you straight to the dashboard. Some of the numbers on there are updated daily. Others will update by the week because there's so much information it has to pull. We put on there like cardiac arrests, respiratory arrests. We put on there motor vehicle accidents, so you can kind of see how busy you are with that. Unfortunately, overdoses, and our annual call volume. As of this morning, Escambia County EMS has been dispatched to 61,544 total EMS calls. That's a lot. If we stay on course, we will surpass last year's 77,334. We may hit 80,000 this year. That's a lot for the staff that I have. If you consider the community I came from, because remember, I was with fire department almost 25 years, fire EMS, same thing. That agency ran about 46,000 calls a year and has almost 3 times the amount of staff I have. So we're busy. Thank you all so much. I appreciate it.
Thank you.
Christy, do we have another presentation today?
Yeah, this is fine.
Next presentation, and I believe we have some items that are going to be on the board, on the screens for you. But we have, we have John Durrani from Durrani.
Yes, ma'am.
Okay, with Levin Papantonio Rafferty to present to you regarding the expected revenues. You've been given handouts which will be added to our minutes so that that'll be available to the public. But there's also going to be items, I'm hoping, up on the screen momentarily. The first, one of the exhibits that you weren't handed today, but he has provided to us, is number 1 in your book. And it's that Florida opioid allocation and statewide response agreement. So you have a copy of that if you want to review that, if he makes references to it, or if you see it up on the screen, you can look at that there. We didn't print off another 20 pages per person.
Good morning, Mr. Chair and members of the board. My name is John Durrani. I'm with Levin Papantonio Rafferty Law Firm. And I'm here today just to talk a little bit about the expected revenues. And I do have, I don't know if y'all can see it on your screen. It's basically a chart that we received from the Attorney General's office with the expected opioid money that should be coming into Escambia County. And just taking a step back, so essentially we had a settlement with 4 of the defendants over the past year. We've been working to get that finalized. The 4 defendants are Johnson & Johnson, which is a manufacturer, and then there's 3 distributors. You've got Cardinal Health, AmerisourceBergen, and McKesson. And so and the reason I mention that is that's just 4 of over a dozen defendants that are out there. So from that settlement, it really, the money is just now starting to go out. Florida is a little bit on the back end of that. I believe today is the first payment that's going to be made to the Attorney General's office, and the Attorney General will then distribute it to the local communities. So we expect for the local communities, such as Escambia, our community, to receive that within the next couple weeks, most likely before the end of October. And so I'm sure y'all are asking, well, how much are we going to get? So from those 4 defendants only, over the next 18 years, there's going to be about $18.6 million. Obviously, it's all to be used for abatement purposes. A lot of the purposes that Chief just spoke about for remediation abatement of opioid related issues, such as, and that's really the reason I referenced that statewide agreement, is you've got treatment, use to treat opioid use and disorder, supportive treatment and recovery, education and prevention are some of the major uses. With respect to this year, what kind of money can Escambia County see? If you look at the first column, it's year 1. You've got, and there's 2 different funds, just to take a step back. Because Escambia County is a region, it gets a regional fund in addition to a direct city and county fund. So at the top, you've got the estimated direct county fund for year 1, which is $219,941. And then for the regional fund, it's $1.554 million. Both of them are supposed to be used in accordance with Exhibit A and B that everyone's been speaking about. So that's the current settlements that have come out. There are still, as I mentioned, about a dozen or a little less than a dozen defendants left. We anticipate and hope that these numbers will at least double. You've got Teva and Allergan, which are both manufacturers. They just settled. The deal's not been inked yet, but that's in the works. And then you've got a significant amount of the pharmacies left, such as Walmart, CVS, Walgreens. And then you've got some of the folks that are in bankruptcy, like Mallinckrodt, Purdue, which was kind of the first one. And then you've got Endo. So we had actually, the state of Florida had reached an agreement with Endo, but unfortunately they filed bankruptcy on day 90 of the clawback period. So we don't know if that money is going to come in this year or if it's going to come in as part of the bankruptcy. And that's really what I came to discuss, is just a general overview of what the revenues look like, and to answer any questions y'all may have.
Any questions, anybody?
So this top one is for the city and the other one's for the county. So basically, they're combined. You basically can look at this as combined funding?
I do, for the purpose of Escambia County, it is.
Okay, so, so really you're looking at roughly for the first year, roughly like 1.7 or so coming in,
Yes, sir.
to be allocated. Okay, I mean,
Yeah, I wouldn't really anticipate, well, so that, let me take a step back even further. So that is year one payment. Year one was last year. So this year, actually, you'd get year 1 and 2. So 1.7 for year 1 and about 1.3. So you're looking at about potentially $3 million total this year that
Okay.
would be paid out.
okay.
When do you anticipate, I know it's kind of taking a shot in the dark, but the settlements on the others coming in within the next 2-3 years, or?
So this process for the first one, and obviously it's probably going to be the longest because it was the first time we've done this, and it's been called the most complicated and complex litigation in the history of the United States, at least. So Tevin, Allergan, it just settled, so we'd be hopeful. I mean, this one took about a year to a year and a half. So hopefully you would start seeing some money before the end of next year, assuming that they can hammer out all the details, ink it, and get all the participation that's required. The pharmacies, we've been in trial. Peter Mouget and Jeff Gaddy, my law partners, are currently in trial in New Mexico. Against Walgreens is the only one left. So we're hopeful that there's one in the near future, but then again, you don't really expect the money for at least about a year. And even going back to these figures, just so you all know, years 1 and 2 of this deal specifically, it assumes maximum participation in the state of Florida. That means every city and county is participating over a population of 10,000, whether or not they're litigating. So over about the past 3 months, we had almost 100% for litigating, but with respect to non-litigating counties, let me think of an example, like Milton, for example. They were not litigating. They hadn't signed the participation agreements, but we got them to sign about 2 weeks ago or 3 weeks ago. So we've only got 10 left in the whole state. So it won't affect any of the payments y'all receive this year, but it could slightly affect the ones for years 3 through 18. And we really just don't know. And we have about a year to get the rest of them in. And we're hopeful that we will. Otherwise, I'm not sure why I'm losing so much sleep at night. So.
Real quick, just as far as the distribution to the counties, you said it comes from the state,
Yes, sir.
and they decide how much, is that based on population, based on incidence, how is that?
So the way it works is, so the state doesn't determine it. They will confirm numbers that the administrator comes out with. And the settlement administrator is a company called Brown Greer, which they're the administrator for the defendants to distribute the funds. It is in part based on population. It's really just based on a subdivision, which would be like the city of Milton, for example. So at 100% participation, these are the figures for 3 through 18. We're at over 99%. It could slightly reduce it, but like I said, we're at less than we're less than a dozen cities and counties left, and we still have about a year to get them in. Because it would not be affected until year 3, which would be next year.
Any other questions?
The estimated number that you just gave about over 18 years, what was that total?
$18.6 million.
Okay.
And as I mentioned, hopefully that will be significantly more as the other settlements come in.
So roughly averaging about $1 million a year or so to work with over 18 years, so,
Yeah.
okay.
I appreciate your information and coming down and spending the morning with us.
Of course. Thank you.
Thank you.
Can you leave your, like a contact with? the
Absolutely,
attorney?
yeah.
Okay, thank you.
All right, Christie, I guess we need to set another meeting time for next month, or you have to coordinate with staff as far as the procurement side of it, or
I'm going to turn that over to Tina.
Tina?
Whatever day you guys would like, I can make sure that either Jeff or Lindsay will be here.
Okay. with that in mind, if everybody look at the calendar and let's, is there a better day? Is Monday a bad day? Because, I mean, you guys coming back from the weekend, and I don't know, Monday might be a rough day.
Monday works fine for me.
Okay,
It works fine for me.
all right, let's look at Monday then. It seems to work for everybody. And I didn't even ask this, but I do think we need to have a discussion. I just kind of jumped ahead, but is everybody in agreement we need to meet again next month before the holidays? Because we're not going to, probably won't meet in December.
Yes.
I would just remind you before you pick a date, I would recommend the 14th only because in the week of Thanksgiving on the 21st. So you, in case you have anyone who decides to travel or has family coming in, you may want to pick the 14th. And that would give us that would be 4 weeks, about 4 weeks out. So we may know whether or not the funds are here.
Okay,
You'll know when we know that the funds are here, we'll let you know. But that'll definitely give you a week of cushion in case it takes longer than expected, and then not interfere with that week when people may be traveling.
okay. I'm open to Monday the 14th.
14th works for me.
Works for me.
I think I'm good on that. I don't see any conflict there.
Are we still gonna do it at 10 or 11?
I say let's stick with 10, that way we can try to, in case we run over a little bit, don't run late, everybody into their lunches and stuff.
People still take lunches?
Some people do.
Oh, that's retired people. I'm sorry.
Okay, with no objection, then we'll set it for 14th at 10 o'clock, Monday, November 14th. Sound good? All right. Any other thing come before the board today?
Yes, when you speak of the exhibits, I'm looking in my book for the exhibits in which he was speaking from as far as the I'm looking for it. In this book here, it doesn't really have a table of contents, and I was looking for, you said Exhibit A that he was reading from, or as his guidelines as far as fund.
I think it's talking about the core strategies that were handed out in the handout here.
Yeah,
the first week.
I apologize. It's Schedule A, not Exhibit A at the top.
Oh, okay, thank you. I'm looking all through the book, thank you, sir.
Okay. Do you want these back? You don't want these back, or do you want them back, or?
No, we're going to just go ahead and reprint for you.
Okay.
And then we can bring the hole puncher next time if there's any pages that you've made notes on and you want to save. You can just hole punch her.
Okay.
And we can take care of that way for you.
All right. Anything else come before the board? If not, we're adjourned.